Well, good morning, everyone. And I'm Dr. Kim Williams, Chair of the Department of Medicine, and it's my pleasure this morning to welcome you all and the family to the 2023 Gaspar Carrasquer Lecture. And we are very pleased this morning to have Dr. Amy Yao, who is visiting us to talk about sodium disorders, but the best introduction always comes from the division chief. And so please, Dr. Youssef.
All right, thank you, Dr. Williams. So I did want to do a little introduction to the Gaspar Carrasquer Lecture. And yes, Carol and his wife is here, and Richard is here also. Dr. Carrasquer was born in Valencia, Spain, and received his medical degree there at the University of Valencia. He came to the United States in 1953, finished his residency in New York, and then came to Louisville. He was a research fellow here. He started working in physiology and then became a professor of medicine and nephrology. He worked at UofL for 49 years. And anyone who knew him knew that it was all about transport. He was all about cellular transport and ion transport. And all of us, even the faculty members, we were always going to him for advice about different channels and how are we supposed to do this and what did he think was going on. Dr. Carrasquer died in October of 2017, and then this lectureship was started in 2018. So in honor of him, I invited Dr. Yao to come speak about sodium. She's an assistant professor at the Ohio State Wexner Medical Center. She received her medical degree there and then traveled around. She did her medicine and internship at William Beaumont Army Medical Center, nephrology fellowship, at Mount Sinai. So she was active military from 2011 to 2018. She has a number of publications. She highlights leadership in nephrology and medicine. Her clinical interests include kidney stones and electrolytes. So I had never actually met Dr. Yao before, but here I am. I'm such a nephrology geek. And I was listening to this Channel Your Enthusiasm podcast, which I recommend for everybody. It is just the most fun podcast. But it is a review of Burton Rose's book, and they talk about physiology of acid base, electrolyte disorders, and all of that. And if you don't know who Burton Rose is, you actually do. You just don't realize it because he started Up to Date. Up to Date was originally just a nephrology program to keep you up on nephrology, and then he expanded it to all of medicine. So again, I invite you to listen to Channel Your Enthusiasm podcast, and now I'm happy to introduce Dr. Yao. Thanks for coming. Oh, sure.
All right, well, thank you so much for having me. I'm going to try to stand over here. I like to go to the slides, so I apologize if you lose me for a little bit. I'm very, very honored and excited, a little bit nervous to be here. So thank you guys for your time. I always warn people, I'm a little bit of a fast lecturer. So if you have any questions, just please stop me, okay? I tend to just get into it. So, all right. So today I'm going to talk about sodium disorders. I'm going to focus on hyponatremia. That seems to be kind of like a big and important topic. But I do want to touch a little bit about hypernatremia. I feel like that's kind of the sodium disorders little stepchild. Everyone kind of forgets it, but there are some updates in hypernatremia as well. And specifically, I want to go through some different challenges and a couple of updates specifically regarding correction rates. There have been a couple of studies that have been out recently, and I think that'll be really nice to go through. So first, we'll talk about hyponatremia. So you guys all know this, right? So hyponatremia is really, really common. We see it often in hospitalized patients, tends to be more common in elderly patients. Also, if you have multiple comorbidities, right? So patients with heart failure, cirrhosis, underlying cancer. And we know that it's more common, like I said, in geriatric hospital wards and in elderly patients also with underlying diseases or comorbidities. So in elderly patients who were diagnosed with community-associated pneumonia, subarachnoid hemorrhage, or COPD, and cancer, the incidence of hyponatremia it can increase anywhere from 8 to 38%. Okay. And the mortality associated with hyponatremia, there is an increased mortality associated. So as you can see here, the lower your sodium is, the increased probability of in-hospital mortality is. And on the in the table, you can see that if you have underlying disease, your mortality risk increases, cancer all the way up to 4.3, underlying heart disease around like 1.5 to 2, and then depending on if you have preoperative hyponatremia, your mortality risk increases as well. Most of the symptoms associated with hyponatremia, so we know this, right? So altered mental status, seizures, confusion. There is, I want to highlight an increased prevalence of falls. So this is sometimes you might hear a patient come in, oh, I fell. We think that it has something to do with the excitability of the neuromuscular transporters, right? So they've actually done different studies of patients who are hyponatremic, and then once they're normonatremic, they measure their reaction time, and so of the nerve conduction velocities. And actually, there is a noticeable delay in the synapses. Once you resolve the hyponatremia, patient's time to get up and go test improved by 2.5 seconds, which is pretty significant. And then the nerve conduction velocity increased by 14%. And also fractures are quite common too. So fractures happen in about 4% of the hyponatremic population, not just because they're falling, but also the bones are a huge reservoir for sodium. So if you remember, it accounts for about 40% of your total body sodium stores. And so if you're chronically hyponatremic, you're going to deplete some of that. It also starts to activate osteoclast activity and reduce your bone strength. And it increases osteoclastogenesis as well. So I kind of want to switch gears and kind of talk about different challenges for hyponatremia evaluation. I'm going to start with a case. There's a couple cases in here to kind of highlight a couple different things, but we'll start with this gentleman of mine. He's a 24-year-old man. He has a history of AML when he was quite young. It's in remission. He had a history of heart failure as well at that time, but it's since recovered. And he's coming in with symptomatic hyponatremia. Basically, 3 months ago, he was in the hospital for sepsis, discharged with a normal sodium of 138, was doing really, really well. He'd actually seen a couple of doctors before this hospitalization in the clinic, no complaints. But for the past couple of days, he wasn't feeling well. He was feeling weak, a little bit off balance. He did admit to a 5-day history of abdominal pain, watery diarrhea, nausea, vomiting, poor oral intake, no fevers, no sick contacts, no, he didn't eat anything funny or anything like that. Medications, he's on metoprolol, gabapentin, he's on Cymbalta. His vitals are otherwise unremarkable. He does have some dry mucous membranes, but otherwise his exam is pretty unremarkable. And so I think here we have a case, he definitely has some risk factors potentially for hypervolemia, right? He has an underlying history of heart failure, maybe something's going on there. He has a history of potential hypovolemia. He's telling you, I haven't been eating very well, I've been having diarrhea and things like that. And you also think about, for me, SIADH, he's on an SSNRI, his vitals are stable, he's got some dry mucous membranes. So by history alone, I think it would be very difficult to say, okay, he's to classify the etiology of his hyponatremia. So these were his labs when he hit the hospital door. So his sodium was 103, his potassium was 3.4, normal creatinine. His urine lights, as shown, the sodium was 52, urine osmosis was 393. He did have ketones in his urine. So before we kind of go through what the diagnosis is, we all know this traditional schema, right? So first you say, is it hyponatremia? Then you look at tonicity, and then you check all the urine, and then you look at volume, right? Volume is really, really important to assess kind of what's going on. But assessing volume is really hard, and we're actually really bad at it, right? So how many times have you had somebody say, come in, see the patient, oh, he's definitely euvolemic. And the next person comes in an hour later, no, he's hypervolemic. And then you might have another consult come in later and say, no, they're dry. They're totally dry. I don't know what you're talking about, right? So we're all, I would say if you ask two nephrologists to see the same patient, you're probably not going to get the same exam. So even in hypervolemic patients, the sensitivity and specificity of symptoms and physical exam findings are actually not that great for assessing volume. And if you're hypovolemic, a lot of the physical exam findings that we typically think of, like dry mucous membranes, decreased skin turgor, are actually not as sensitive and specific as we would like it to be. And additionally, that traditional schema, it doesn't really take into account the different mechanisms of hyponatremia, right? So I always tell people that you cannot get hyponatremic unless you're drinking water, right? So if you're not drinking any water to hold on to free water, then you won't get hyponatremic, right? You have to have some sort of input in free water. So these people definitely are having a relatively high free water intake, okay? They're also having impaired free water excretion in the urine, all right? And that's part, and whether that's appropriate or inappropriate, that's for us to try to figure out and try to assess. Let's see. So the newer schema that it came out about a decade ago in the European guidelines are to say, okay, once you have somebody with hyponatremia and once you confirm it's hypotonic, first, think about whether or not you have to acutely address their symptoms, right? So are they seizing? Are you worried about coma? Are you worried about them protecting their airway? If you are, then manage that first, okay? After that, once you've determined they're asymptomatic or mildly symptomatic, have a little bit of time to kind of think about it, okay? And the first thing would be to actually look at the urine studies, and we'll kind of go through this. And then the volume assessment is one of the very, very last things. And I think this is really nice because you can say, does your volume assessment match up with what the urine is telling you? I always tell people the kidneys don't lie. They know what they know what they're sensing, and it's your job to kind of make sense of that in the setting of the clinical picture and the patient that you're seeing, okay? So again, after you confirm true or hypotonic hyponatremia, you want to look at the urine. The first thing is to look at the urine osmolality. This is going to be to assess your ADH response, right? So ADH helps to hold on to free water, right? So if you have dilute urine, your urine osms are low, that means your ADH is off, right? I'm not trying to retain any free water, even though I'm hyponatremic, right? So I'm hypotonic. I don't want to retain any more free water. So then why is the patient hyponatremic? Then they must be either drinking in free water or they can't excrete the free water because their solute intake is so low, okay? Or your ADH is high, your urine osms are high, and then the question is it high because it's appropriate or is it inappropriate? And so this is where nephrologists kind of overlap with endocrinologists when we think about patients. Is it appropriately elevated or inappropriately elevated? Okay. And the question is why not just measure ADH, right? Like, why do we have to look at the urine? Can't you just check the ADH in the blood and just see what's going on? So ADH itself is actually not a very stable and reliable protein to be measured. It can be in research laboratories, but clinically it's just not as easy to measure as we would like. So what you can do is you can measure the copeptin. So as ADH is made by the body, it starts as this pre-pro vasopressin, and the copeptin, the tail end of the protein, is cleaved off. And copeptin is actually used quite a bit by endocrinology when assessing for diabetes insipidus. So it is a test that we do use in sodium disorders. So why not measure it in hyponatremia? So there was a large study of 298 patients with hyponatremia less than 125, and there was actually no discrimination for copeptin except to discriminate for patients with primary polydipsia, okay? So it's not, unfortunately, it has not been very helpful in that clinical setting of hyponatremia. After looking at the urine osmolality and you find that ADH is on, then you want to assess your RAS response, right? So if RAS is on, that means you're trying to retain sodium. Okay, so if I retain sodium, that makes sense that my ADH would be on, right? Why do I need to retain sodium if my blood pressure is low? So I want to retain salt to maintain volume, and also ADH, which is water. It's not a lot of volume, but it's a little bit of volume, so to retain volume as well, right? So in this setting, the kidney is sensing a low effective arterial blood volume or a low kidney perfusion volume, okay? Whether or not the patient is actually hypervolemic or not. If your urine sodium is elevated, that means RAS is off. And so either it's off because you're influencing the exam test, right? So either they're on a diuretic or they have some underlying CKD, or the ADH is inappropriate elevated, right? So the kidney is not trying to retain salt. It doesn't sense a low volume, but still for some reason ADH is on, okay? And then the very last thing would be the volume, okay? Apologies. So back to our case. So this is our gentleman, right? So what does the urine show? So here we see a patient with a true hypotonic hyponatremia. I'm sorry, I didn't put the serum osms on there for you. Your urine osms are elevated, right? So I know ADH is on. And is ADH on appropriately or inappropriately? Now I'm going to look at my urine osms, right? Or I'm sorry, my urine sodium. And my urine sodium is elevated, right? So now my ADH is inappropriately elevated. So, I'm thinking SIADH is kind of on my differential, okay? There's some other workup we need to do, which we'll kind of go through first. And so he was actually diagnosed with SIADH. And when you get more history from him, he says, oh, actually my Cymbalta dose was increased a couple of weeks ago. And we think in this gentleman, that's probably kind of what precipitated things. So a couple of pitfalls when we're assessing hyponatremia. The impact of age and kidney function on the diluting and concentrating ability of the kidney. So in a patient with AKI and CKD, if the CKD is very advanced, the urine osm will range from anywhere from 200 to 300 maximally, okay? So your, a normal urine osm can get as dilute as 50 milliosms per liter and get as concentrated as 1400 milliosms per liter. As you get older, you lose a little bit of concentrating ability, but you also lose a little bit of diluting ability, okay? And then patients with CKD also have that impaired, that their range of urine osms can decrease over time, okay? And a lot of these studies with age and the urine osmolality change has actually been done way back, like a long time ago as well. So this is a nice example of that. So this is one of my patients, 63-year-old female. She has type 2 diabetes. She has a known history of CKD3 or baseline creatinines 2. A couple years ago, lost a follow-up. She comes in because she fell. She basically had diarrhea for the past month, multiple times a day, no vomiting, a little bit of dyspnea and fatigue. She was getting up from her sofa, felt a little bit lightheaded and dizzy, and fell, okay? And she does say she drinks a lot of water. She needs to because of her kidneys is what she says, okay? Her exam is unremarkable, but she's got crackles up to her mid-lung field. She has 2+ pitting edema to her thighs. So here we have a history and exam that is not necessarily concordant, right? She's telling you, I'm dizzy, I'm lightheaded, right? She's telling you I've been having diarrhea, right? But her exam, she's clearly hypervolemic, I would say, right? She was given a liter of saline because she did fall. She was saying she was dizzy. Her sodium was 105, potassium was 5.1. Her creatinine is up from her baseline, 3.4. And her urine studies are interesting, right? So she has an elevated urine osm and her urine sodium is low. So, I think the overnight physician felt like, well, she got a liter of saline. These urine studies were done after that. Maybe she's dry and she turned off her ADH, right? And so I'm really worried. I mean, her sodium's 105. I'm very, very worried about her overcorrecting, okay? So they give her 4 mics of DDAVP overnight. They do start some normal saline. They say, okay, the ER is saying that she's dehydrated, even though they have this exam finding, just start some fluids, give her some DDAVP so she doesn't dump out all that free water and overcorrect, okay? But the next morning, she didn't make a lot of urine, and her repeat urine osm is still 250. So DDAVP is basically synthetic ADH, okay? It should concentrate your urine quite a bit, okay? But it didn't. It didn't concentrate her urine really at all, okay? And why is that? Basically, later that day, she had a large pericardial effusion, and kind of the picture was put together. Like I said, she was lost to follow-up, and essentially she was diagnosed with kind of CKD, and hypervolemic hyponatremia due to her renal insufficiency, and she was started on dialysis. So even though she was making urine, she was not able to dilute or concentrate her urine very well. And you can see here that her urine osmoles, just the range was quite small in her, okay, despite getting a large dose of DDAVP, I would say. The next pitfall is about renal and cerebral salt wasting, okay? If it exists, it's probably very rare. When I was a medical student and a resident, I was a huge believer in cerebral salt wasting. It's true, it's here. We just got to find the right patient, right? And so how do you differentiate between cerebral salt wasting and SIADH? The classic teaching is these patients are losing salt in their urine, okay? The kidneys, either the brain pathology is causing the kidney to lose salt, or the kidney disease itself is causing the patient to lose salt. And so the patient is hypovolemic. So that's going to be the key, right? You have a patient who either is orthostatic or whatnot, and versus an SIADH patient, which we consider to be euvolemic, all right? But the range of the incidence of cerebral salt wasting are kind of all over the place, right? So as high as 94% of patients with subarachnoid hemorrhage will have cerebral salt wasting, and as low as 0% of patients. So that means there's some flaw in the way that we're looking and diagnosing cerebral salt wasting, okay? For a disease to either be very, very prevalent or not prevalent, there's some analysis abnormality. And kind of the biggest and the best study to look at is that last 2014 study that had 100 patients with subarachnoid hemorrhage, and they were followed for 12 days. 49% of them did develop hyponatremia, and when they did all the evaluation, which was a very comprehensive evaluation, 71% of them actually had SIADH, okay? I think that this is something to kind of keep in mind. There's we always worry that cerebral salt wasting is there, but don't fall into that trap, I would say, because a lot of these patients are not actually hypovolemic, or in fact, they're hypervolemic because they're been getting saline or salt and whatnot. And so just make sure that you're doing a comprehensive evaluation of these patients, okay? And the last pitfall that I wanted to talk about is to remember that SIADH is a diagnosis of exclusion, right? So I told you about my young man who was on Cymbalta, who was diagnosed with SIADH, and I said, okay, he's on Cymbalta, the urine studies look like SIADH, we're going to call it SIADH, right? So there are multiple causes of SIADH. So definitely if you have some sort of CNS disease, different medications, SSRIs, SNRIs, TCAs are really common, different types of cancers and malignancy. There is also a genetic cause of SIADH. It's X-linked recessive, and it affects the AVP receptor, okay? And don't forget, nausea, vomiting, pain, those are all very strong stimuli for ADH release in the brain, okay? But again, it's a diagnosis of exclusion. And so if you remember back to the old schema, you really have to rule out adrenal insufficiency and thyroid dysfunction, okay? And these are often not checked in patients with euvolemic hyponatremia. So these are 6 different studies of patients with SIADH, and they went back to see how many of them actually had thyroid function tests and adrenal function tests done. Anywhere from 50 to 90% of them had thyroid function tests, and around 30 to 100 patients of them did have adrenal function tests done. And when they went back and looked, of the patients, the number of patients who were diagnosed with hypothyroidism or adrenal insufficiency it's not insignificant, anywhere from maybe 4 to 8%, I would say. Okay, so this is the urine studies for someone with adrenal insufficiency will look just like the urine studies for someone with SIADH. Okay, so it's really important to rule that out. Thyroid disease, I would say, is a cause of hyponatremia in the setting of either really mixed edema coma, or if your TSH is above 50. So if the TSH is like 15, it probably is not contributing to the hyponatremia, okay? But the prevalence of thyroid adrenal insufficiency and hyponatremia is around 3%, and the prevalence of hyponatremia in patients with hypopituitarism is up to almost 10%. And actually, the hyponatremia was the key to diagnosing the endocrine disorder in up to 80% of these patients. Okay, so make sure that we're not missing that diagnosis in patients. All right, moving on to the management of hyponatremia. So before we go into the management, I think it's really important to understand how the cell responds to the environment. How does it respond to hypotonicity and hypertonicity? And once we understand what the cell is doing, then we can kind of talk about the therapies and some of the complications of the therapies. So when cells are exposed to a hypotonic environment, so as if I drop a cell and put it in a glass of free water, okay, they're going to undergo something called regulatory volume decrease. So basically, if I drop a cell, put it in free water, all that free water is going to want to go into the cell, right? So now my cell is hypertonic to it, okay? And the cell does not want to swell like that. It doesn't like it, okay? And so in order to do that, it's got to get rid of some things inside of it, so that way it can get smaller again. So that's why we say regulatory volume decrease. And it does this in an organized fashion, okay? So they lose different type of osmolytes, inorganic osmolytes. So these are different types of electrolytes, sodium, potassium, and chloride, and then also loses it through organic osmolytes. These organic osmolytes, the ones most studied are taurine and myo-inositol. There are also different amino acids, glutamine, glutamate, and things like that, okay? And, this happens actually really, really quickly. I'll show you in a little bit. And how do the cells know to do this, right? So there is a stretch mechanism that we still don't quite understand. We think that it has something to do with the cellular cytoskeleton interacting with tyrosine kinase inhibitors and integrins on the cell membrane. And what that does is it somehow senses things, causes activation of G-coupled protein receptors that stimulate calcium, protein kinase A, protein kinase C, to help excrete and allow potassium to leave the cell, chloride to leave the cell, and also allow different type of organic osmolytes to leave the cell. When all those osmolytes leave the cell, water is not going to want to come into the cell as much, okay? And like I said, in rat brains, this happens within a few minutes, actually, okay? So the cells can respond to a hypotonic environment and maintain their cell volume by close to 70 to 80% of what it was before within a few minutes. So here in panel A, we can see they put a cell in a hypotonic solution. And so that's the volume size. Within, I would say, about four minutes, the cell volume rapidly approaches kind of its baseline cell volume, okay? And the way that it does that on the panel B, you can see here that, the chloride efflux, that's how much chloride is leaving the cell, is quite large at the beginning. So all of a sudden the cell is saying, oh my gosh, I'm starting to swell. I need to stop this, okay? And it's gonna release chloride or allow chloride to leave. The other thing that leaves is potassium, not as rapid, but it does leave the cell. And then the last thing is taurine. So the other kind of a measured osmolyte is taurine. And again, like I said, so this happens as early as a couple of minutes, and probably the maximum effect that you're getting is after about 3 hours. So at 3 hours, I've maximally released all the osmolytes that I can from my cell. And, over time, like I showed you here, potassium release is a little bit, the slope of it is not as steep, partly because potassium is being released, but then it's also being it's also being reabsorbed by the cell, almost like potassium recycling. We think that potassium is important to help extrude other organic osmolytes, right? So you don't want to deplete your potassium all the way, because otherwise you're going to have limited extrusion of your osmolytes, right? So I think that's part of the reason why potassium is a little bit limited. And we can see here that the percent of osmolyte loss. So you do lose some electrolytes at the beginning, but overall, when you look at brain cells, a day or two later, the biggest osmolyte loss are these organic osmolytes. So taurine, myo-inositol, glutamate, and all these other organic osmolytes. And then when I put my cell in a hypertonic solution, right? So now I'm going to put it in salt water. Okay, they're going to undergo something called regulatory volume increase, right? So I put my cell into salt water, and what's going to happen is now my cell is hypotonic to its environment, and water is going to leave the cell, right? Because it to maintain tonicity. And if water leaves the cell, then the cell will shrink. The cell doesn't like shrinking either. It doesn't like swelling. It doesn't like shrinking. It just wants to be the same size. Okay. And so the way that it does that is it tries to take in different osmolytes as well to maintain its size. Okay. So again, it does this mostly. So where regulatory volume decrease includes the efflux of electrolytes through different different channels, the input of electrolytes into the cell occurs through different co-transporters. Okay, so I can just lose chloride through a chloride channel just by itself; it'll just leave the cell. But to get chloride and sodium and potassium into the cell, I need my NC co-transporter. I need my NKCC co-transporter. Okay, so it's a little bit of a more dependent process. Okay. And then the organic osmolytes come in as well, sodium dependent and potassium dependent. And then with that, water will move into the cell or be retained in the cell. Okay. And the accumulation of osmolytes into the cell actually starts to maximize around 9 to 24 hours, but really reaches steady state around 2 to 7 days. And so it takes a long time to accumulate those osmolytes compared to losing the osmolytes. It takes up to 3 hours. Okay. So I know that was a lot of cell physiology, so I apologize. But in summary, when you develop hyponatremia, okay, the cells undergo regulatory volume decrease to avoid swelling. They lose all their electrolytes and osmolytes. Okay. Then when I correct it, now my cells are at risk of shrinking, right? And so they need to now gain everything back so that way they maintain their size. When I have someone who is developing hypernatremia, they undergo regulatory volume increase. And so they're going to gain all these electrolytes and osmolytes. And then when I correct that, now my cells are at risk of swelling, or what we say, clinically cerebral edema. And I need to lose all these electrolytes and osmolytes to maintain size. Okay. So I want you to kind of keep this in mind as we go through some of the management steps. And we'll talk about it specifically when we're talking about risk of osmotic demyelination. So, I had talked about the newer guidelines say the first step after noticing someone is hyponatremic is to determine if they're symptomatic or not. And if they're symptomatic, acutely symptomatic, seizure, worried about airway, worried about altered mental status, you can give them hypertonic saline. And there's actually good data showing that bolus is probably better than continuous infusion. So bolus infusions actually improve your serum sodium. They both increase your serum sodium. You probably get a quicker rate of rise with the bolus infusions. And also you have an improvement in your GCS score much quicker with the bolus infusions over the drip, okay? So if you have someone who's actively seizing, don't worry about a drip, just bolus them, okay? And someone who is asymptomatic and you're thinking about chronic management, that will depend a lot on the mechanism, okay? So, you definitely, if you can, try to reduce the free water intake, and then you want to help the kidney get rid of free water, okay? And so again, if you're reducing free water intake, you can just reduce their free water intake, restrict them if you can, in order to help get rid of free water in the urine. You can either normalize the blood pressure if the patient is hypovolemic, somehow stop the suppression of ADH, stop the medications if you can, give them cortisol if they're adrenally insufficient, tolvaptan, treat the underlying kidney disease if someone has an AKI, right? And so if you can, and then non-electrolyte solute excretion. So basically inducing a solute diuresis with urea, SGLT2 inhibitors, increased protein intake, and we'll kind of talk about that, okay? The other thing that you can do if you're really, really worried about them, is something called the DDAV clamp. I don't know how many of you have done this or heard of this before. But this is to be done in the situation where you are worried about somebody overcorrecting, but you definitely want to improve their serum sodium. And essentially, you make them like a closed box. You give them DDAVP. You say, hold on to all that free water. Don't lose it. Okay, I'm going to give you DDAVP so your ADH doesn't turn off. Whatever your stimulus for ADH is, even if your nausea goes away, I'm going to give you DDAVP so you hold on to free water. If I stop the medication, I'm going to give you DDAVP so you can hold on to free water. And then I'm going to give you salt. I'm going to give you hypertonic saline to improve your serum sodium to a level that I feel comfortable at. Most people will stop around 120. And then once your sodium is there, I'm less worried about inducing osmotic demyelination syndrome. Then I'll stop the DDAVP and then you can pee out all the extra free water. Okay. I've done this a couple of times, mostly in patients that I'm worried about overcorrecting. And then the very last thing you can do, if you need to, is dialysis. Okay. So for our gentleman with SIADH, our young man, he is on Cymbalta. So one of our therapies could be to stop the medication. But for SIADH, I would say this is really where a lot of the therapies we have are a little bit harder they're harder to manage, I would say. Okay. So for SIADH specifically, how effective are different therapies for hyponatremia management? So if you do nothing or stop the offending drug, you do have a change in serum sodium by about 5 milliequivalents in about half the patients. Fluid restriction does work, right? So it does improve the sodium in about 44% of patients. But the addition of salt and salt tablets to patients who are fluid resuscitated, probably not a significant change, okay? And if you look to, in terms of improving the sodium above 130, 135, I wouldn't say that it's actually much different. Tolvaptan, yeah, it definitely gets your sodium above 135. That's probably the one in this table that is the most effective in normalizing the sodium in patients. But it does come with a cost, right? So it's a higher risk of overcorrection, just like hypertonic saline. And like I said, stopping the offending drug, it does help to normalize patients above a sodium of 135. Another trick to consider in this table that they didn't really talk about is furosemide, right? So, we know that in SIADH, your urine osmoles are what we say fixed, meaning that I'm secreting a certain amount of ADH to maintain my urine osmolality to a certain level. Let's say it's 500 or 600, okay? And so if I can't turn that off, another way is to limit the effectiveness of the ADH by limiting how much free water is being reabsorbed. So a way that I can do that is to block NKCC2. So NKCC2, if you guys remember, helps to concentrate your medullary concentration gradient, okay? If I don't have anything in my medullary concentration gradient, no matter how much ADH I have, I'm limited with how much free water I can reabsorb, right? And so now I've dropped the osmolality of my medulla, and so I can't reabsorb as much free water. It makes your urine what we say isosostanuric, so the same osmolality in your urine as in your plasma. Okay. But they've done studies. This is a nice study out of Thailand, and they show that if you free water restrict someone, even if you add furosemide or if you have furosemide plus salt, there's probably actually no difference in the outcomes, okay? So even though these are all little tools and tricks that we use, we love using the physiology, clinically, it actually doesn't make a huge difference in the outcomes, okay? Which is a little bit frustrating, I will say. Fluid restriction, like I mentioned before, can be helpful, and you can kind of predict which patient is going to really respond to fluid restriction by using something called the first equation. So the first equation came out in 2000. It's kind of like a simplified derivation of the electrolyte free water clearance equation, okay? Basically, you're looking at the electrolytes in your urine compared to the electrolytes in your serum, and you're saying, am I trying to pee out free water comparatively to my serum, or am I not? And that will determine how much free water restriction you have, because basically you want them to pee out more free water than they're taking in, essentially, okay? And so based off of their first equation, you might say if their first equation is low, then they're likely to respond just to free water restriction alone, and you can fluid restrict them, okay? I personally don't like to fluid restrict patients because they don't always do it at home unless the patient tells me, oh, I was already drinking 3 liters or a gallon of water a day at home. That patient you can probably fluid restrict. But if the patient is not actively telling you I'm drinking a lot of water, it's hard to tell them to fluid restrict even more. If the first equation is above 1, then they're probably not going to respond to fluid restriction alone, and they probably need something in addition to fluid restriction in order to normalize their sodium. Dr. Ronda, and I don't know if any of you guys know him, he's at University of Pittsburgh. He's a big advocate of urea. I think urea is wonderful, but we'll talk about some of the limitations of these medications too. So inducing a salt diuresis with salt tablets is actually very difficult, and urea may be better to do that. Again, a solute diuresis is going to excrete solute and free water with that too, okay? So 1 liter of normal saline is about 9 grams of salt, okay? And 1 gram of salt is about 34 milliosms. So if I want to give someone 500 milliosms of solute, I have to give them 15 salt tabs. That is very uncomfortable. It is not very pleasant. Salt tablets are not nice to take, okay? Or I can give them 30 grams of urea, which I heard is also not as palatable, but probably better than the 15 tablets, okay? Or you can give them a high protein diet, protein intake, okay? And urea does appear to be safe to use even in ICU settings. So this was a nice kind of review that looked at different studies that looked at urea in the ICU setting. And as you can see that it did improve serum sodium levels from anywhere from 112 to 131 to normalize the serum sodium. This is probably in combination with fluid restriction and other therapies as well, since they were in the ICU too, okay? Another way to improve the serum sodium is to use SGLT2 inhibitors. So this has kind of been studied. Basically, SGLT2 inhibitors are inducing a solute diuresis, right? You're peeing out glucose. When you pee out glucose, you're going to pee out free water with it as well, okay? And so this was looking at 25 milligrams of empagliflozin for 4 days. There was no adverse reaction, and they thought that theoretically it could be used maybe in patients with cirrhosis or if there's a secondary indication for SGLT2 inhibitor use. So if I have a patient that's coming to see me, maybe they already have some underlying heart failure or they have some diabetes and they have a little bit of SIADH, then I'm probably more apt to maybe adding an SGLT2 inhibitor too. They're probably going to need it for their diabetes or their diabetic kidney disease, their microalbuminuria, and so that may help their hyponatremia as well. I really do love Vaptans, and I love the idea of Vaptans because it is really the only drug that is targeting the mechanism of action of SIADH, right? So we said SIADH is increased ADH causing aquaporin insertion into the collecting duct, and so Vaptans inhibit that recycling process, okay? It binds to the V2 receptor, and it doesn't allow the aquaporins basically sit at the basolateral surface and just wait for the signal to kind of combine with the membrane and go in there. So it's very easy for them to get there. And so what Vaptans do is they inhibit the recycling of aquaporins from the membrane. Okay. But is it safe, right? So, I was telling Dr. Williams earlier that that there's this huge black box warning, cannot use in patients with cirrhosis, not supposed to use in patients with cirrhosis because so Vaptans are also used in autosomal dominant polycystic kidney disease at doses of around 60 milligrams a day as a starting dose, up to 90 milligrams a day. And what they found in those patients is that there was an increased incidence of LFT abnormalities. They increased up to 3 times to 6 times the upper limit of normal, and patients had to stop the drug actually because there was this LFT abnormality. And so because of that, the FDA put this black box warning on all Vaptans, regardless of the dose, okay? But the dose that we use for SIADH and hypervolemic hyponatremia is actually up to 45 milligrams. So it's not even at the dose that we would typically use for someone with ADPKD. And I have used this in cirrhotic patients, probably short term, maybe in the setting to get them to liver transplant or something like that. And I think it's okay to do in those sort of monitored situations. The only problem I would say with Vaptans and urea is that it's difficult to get as an outpatient. So the other thing I like to think about often is whatever I'm going to be doing in the hospital to normalize their sodium, is that something that the patient is going to be able to do at home to prevent readmission, right? I want them to maintain normalizing when they leave the hospital. So if I'm giving them 60 grams of urea in the hospital, can they get that as an outpatient? It's technically not FDA approved. It's considered a supplement. So they can't get it from their pharmacy. They have to get it either from Amazon or another commercial entity. Okay. And so one, can the patient afford it? And two, will the patient take it, right? And then the other thing is Vaptans. So Vaptans are quite expensive now, unfortunately. Even if you have private insurance, you typically have to jump through a lot of hoops to get it approved. And so it can be really difficult for patients to leave the hospital on a Vaptan. And so, I think the one last patient I put on a Vaptan, tried to get her as an outpatient. She had underlying malignant melanoma. And I think it took about a month for me to get her the Vaptan. And so she actually got readmitted twice in that month because of recurrent hyponatremia. Okay. So I think, unfortunately, those are, even though we have all these great tools now for SIADH, it really limits what we're able to do as an outpatient. I think SGLT2 inhibitors are a really nice kid on the block, a little bit easier to get approved for most patients if they can afford the copay. But I think that's unfortunately why our therapies are not potentially as effective as an outpatient. And the last thing I'd like to talk about in regards to hyponatremia is finding the optimal correction rate. So the EU-US guidelines do recommend, if they're asymptomatic, to correct around 8 milliequivalents a day, potentially lower if you have someone with risk factors for osmotic demyelination, okay? But they say probably try not to aim for more than 10 milliequivalents a liter a day. And there's a couple of studies that show that, and a lot of this comes from the concern for osmotic demyelination. So even though we know osmotic demyelination is rare, you don't want to be the patient or the physician whose patient develops osmotic demyelination, right? So, and we do so many things in medicine to not to protect ourselves, but to protect patients from even rare complications, right? And so there was found to be no mortality benefit to slowly correcting somebody. And so that's why I would say a lot of people, especially if the patient has a starting sodium that's very low, will err to correct somebody really, really low, because you don't want to be that one physician, that 1 in 1,000, to have that one patient with osmotic demyelination, okay? But there are a couple of newer studies that came out just this year that show that rapid correction maybe is not as bad as we thought it was, okay? So this was a study of about 1,000 patients. Their mean sodium was 116 to 117, and actually their in-hospital mortality was lower if they corrected more than 8 milliequivalents a day compared to less than 8 milliequivalents a day, and there was no difference in neurologic complications. So even though the rapid correction, that there was 25% increase in neurologic complications at discharge, the adjusted absolute difference and the 95% confidence interval based off statistics, it was not significant. There was less hospital free days and ICU free days, which makes sense, right? So if I'm normalizing someone's sodium quicker, then I won't need to be in the hospital quite as long. And there was actually, this just came out, I think, a month ago by one of my friends in Boston. They actually show that if you correct someone slow, they're actually at higher risk for in-hospital mortality, right? Compared to correcting someone fast. So they looked at groups correction less than 6, a correction between 6 and 10, and a correction more than 10, okay? And they said, if you correct, or they showed, if you correct less than 6, your in-hospital mortality was much, much higher than if you corrected more than 10. Especially if you had underlying cancer and underlying heart failure. So does this mean that I'm correcting all these people slow, that it's worse? And should I be correcting everyone fast now, right? Like, has my whole paradigm changed? And now I just need to correct everyone fast. I've been doing nephrology wrong for the past couple of years. I think some things to kind of keep in mind from these studies, right? So is the hyponatremia and the mortality really a marker of the hyponatremia itself, or is it a marker of their underlying comorbidities, right? So is that patient who is slowly correcting, or or do they also have underlying heart disease, cirrhosis, other comorbidities that are leading to the hyponatremia. And are all these people who are correcting slow, is it because we wanted them to correct slow? Or like I said before, our therapies for SIADH are not that great. Maybe we wanted to correct them faster, but they didn't correct faster, right? And so I think that is not parsed out in this data. So, you know, I don't think that this data necessarily changes my approach to correction rate of hyponatremia because of that. Because again, these are all retrospective studies, okay? There was another study that came out, which I'll kind of touch about, the Macmillan study that also came out a couple of months ago, that looked at hyponatremia. They found the incidence of that study mostly focused on the incidence of hyponatremia. Osmotic demyelination and hyponatremia treatment. They found it to be very, very low. And they said kind of further research needed to be done. They thought that rapid correction did not necessarily make things worse. But if you look at these different studies, so even Harish's study that just came out about a month ago, and Macmillan's study that came out a couple of months ago, both in New England Journal of Medicine Evidence, and then an older study in SIADH. If you look at the patients who developed osmotic demyelination, so we know it's rare to begin with, right? So anywhere from 0.002 to 0.05% of patients develop osmotic demyelination. The mean serum sodium in these patients were as shown. The Macmillan one, they didn't note their serum sodium in the osmotic demyelination patients. The mean serum sodium was in the total population of the 22,000 hospitalizations. But if you look here in George's analysis in 2018, the risk factors are patients with beer potomania, alcohol use, so malnutrition, these low solute people, okay? If they also had hypokalemia, if they had hypovolemic hyponatremia and thiazide use, okay? And Harish's paper, again, we're seeing similar themes: malnutrition, alcohol use, hypokalemia, hypophosphatemia, okay? There was no discrimination on the etiology of hyponatremia. And then in Macmillan's paper, again, these patients had a higher comorbidity burden. They had a lower serum sodium level, so they were 111 compared to the 125, okay? They had urine sodium less than 30, so higher rate of risk of overcorrection. And they also had a hypokalemia. More than half of them had hypokalemia compared to the patients, the non-ODS group, which again was much larger, but 86% of them had normal kalemia. And this is kind of in line with what the US guidelines say. They say the patients at high risk for osmotic demyelination are those who start with a low serum sodium, who are hypokalemic and essentially malnourished or have low solute from alcoholism, malnutrition, or advanced liver disease. And I want you to kind of go back to what we were talking about regulatory volume decrease and increase, right? So the electrolytes and the osmolytes that are important to maintain cell volume, we talked about potassium, we talked about chloride, and we talked about amino acids, right? And so if you are already deplete in those electrolytes, you are not going to be able to regulate your cell volume in response to different types of tonicity environments, okay? And so it makes sense that these are the patients that are at risk, okay? And so I would say that the best thing from these studies, you know, we already know ODS is rare, but to look at what these clinical parameters are telling us and combine that with what we know about cell physiology, and then really trying to better identify which patients are at risk for ODS and which patient do I actually need to be a slow correction rate on, and which patient, if they overcorrect, I'm not as worried about it, okay? And the guidelines do say that you only really need to overcorrect if their risk is high and if their starting serum sodium is low, because we know the risk of ODS, if your serum sodium is above 120, is quite low, okay? And I try to impress this on the fellows, but I think sometimes you get ingrained. You think about that 6 to 8, and all of a sudden it's 9, and you want to fix the overcorrection. But I think you know, just being judicious. Not every patient is the same, and every clinical scenario is the same. Okay. So when we think about correction, a couple things. So not all overcorrection is the same. So this was a study that was done in rat brains. They were given hypertonic saline, Vaptan, which is the red line, and urea, which is the green line. And we all see in it, they started at around a serum sodium of 110, and they all normalized 24 hours later, okay? But we can see here that the patients, or the rats that got urea, had a better neurologic score days later than patients who were treated with Vaptans and hypertonic saline. And they actually had improved survival when you're looking at, around 10 to 12 days. So potentially overcorrection or correction with medication like urea may be a little bit better. The authors postulated that it may be due to the rate of correction over that 24-hour period, right? So potentially Vaptans and hypertonic saline corrected the sodium really quickly and then maintained that normal sodium versus urea, where the slope was maybe a little bit slower and the cell was able to handle that osmotic stress a little bit better. The other pearl is to remember your other electrolytes, okay? So specifically potassium. So if I have a cell that is in a hypotonic, hypokalemic solution, right? So the potassium is low and the sodium is low. If I give them potassium, that potassium is going to go into the cell. Okay, we already, right? So their total body potassium depleted. So most of the potassium is stored inside the cell. So the potassium is going to go into the cells. What happens then is sodium and hydrogen are going to leave the cell, but the hydrogen is actually buffered by different types of buffers in the body. And it basically neutralizes that effect. Okay. And then because of that, water is going to move into the cell. And essentially, you're not just increasing the serum sodium. And so essentially, you're increasing the serum sodium. Okay. So I like to show this example. This is a patient of mine from fellowship, actually. 34-year-old man, history of asthma, comes in with nausea, vomiting. He's tachycardic to 142, sinus tach. Blood pressure is normal. Otherwise unremarkable. His labs, he comes in with not too bad, sodium 121. His potassium is really, really low. He has this profound metabolic alkalosis. His lactate's over 15. And those are his urine studies. So his urine sodium is 20, so less than 30. And his urine osmoles are not too bad in the 200s. And so we said, well, it's probably hypovolemic, hyponatremia. And what we did is we gave him just potassium. We didn't give him any. Other than fluid restriction, we didn't give him any saline, right? He's hypovolemic hyponatremia. We normally would give him saline. We just gave him potassium. And as you can see, his serum sodium, the orange line, improved really nicely from a sodium of 121 to a sodium of 134 within 4 days, okay? So I think this is something to think about too, right? Again, potassium is important to maintain cell volume, and it's also can be used to help normalize someone's serum sodium if the patient is also hypokalemic, okay? Real quickly, because I know we're a little bit short of time, but I really do want to touch on hypernatremia. So the prevalence is quite high in ICUs. The out-of-hospital mortality is actually quite high too. And there's a lot of similar neurologic symptoms as well, okay? Mechanisms of hypernatremia. So you don't, again, just like you don't get hyponatremic unless you're drinking free water, you don't get hypernatremic unless you have some sort of impaired free water intake, either impaired access to free water or impaired access to free water or impaired intake of free water, okay? Plus one or more of the following. Either I'm giving them salt, I'm making them hypertonic, okay? Or, salt poisoning. There are multiple case reports actually out of Asia where people unfortunately do suicide ingestions with drinking soy sauce, which is very salty, extrarenal water losses, and then renal water losses. Renal water losses, we're looking at whether or not this is a water diuresis, so either a central or nephrogenic DI or an osmotic diuresis. And, to assess this, to look for salt loading, you will look at how much salt you're putting in versus how much they're coming out. To assess for water losses, renal or extrarenal, we look at the electrolyte-free water clearance. And then to look for solute diuresis or water diuresis, we would kind of look at the urine osmoles. So this is a nice example I would like to talk about a patient to how to approach this algorithm. So the consult is for hypernatremia. Their other electrolytes are normal. They're making 9 liters of urine a day. Urine osmoles is 368, and those are their other urine lights. So I think the first question, excuse the animation, but the salt loading, the patient's not getting any extra fluid, okay? So they got saline when they first came in because she was septic, but none since then. And then in terms of, are they having extrarenal or renal water loss based off of the electrolyte-free water clearance is positive. So they're basically having a renal water loss, okay? So are they having renal water loss from a water diuresis or a solute diuresis? And that's where you look at how much osmoles they're excreting in their urine. So normal person takes in about 800, 900 millosms of food intake a day, okay? So if this person was excreting over 3,000 millosms a day, right? So she's clearly having a solute diuresis, okay? And then if you ask what kind of solute diuresis, you have to look at their individual urine lights by the volume. And for her, she was having a significant salt diuresis, probably from all the saline that she got earlier in her hospitalization, okay? So management of this, you already gave her the saline, you can't stop that anymore, but is really just to kind of keep up with her current free water losses. So again, to correct her sodium, we want to calculate her current free water deficit plus ongoing losses, okay? And correction of hypernatremia, there's a concern for cerebral edema. A lot of the DKA HHS guidelines do recommend lowering the effective osmoles by around 3 milliosmoles per kilo per liter. So for an adult, that translates to around 8 milliequivalents per liter an hour, okay? And the loss of organic osmolytes is slow. And so that puts cells at greater risk of swelling. So again, we talked about when you undergo hypernatremia, they try to avoid shrinking. And then when I'm correcting the hypernatremia, the cells are at risk of swelling, okay? And the brain can accommodate a volume change of around 12%, all right? So probably, so we do need to limit this some. And in patients, so this is a rat study that showed that in rats who were exposed to chronic hypernatremia, when you put them in an isotonic solution, they overshot their volume, okay, versus rat brains who are exposed to acute hypernatremia, meaning that patients with chronic hypernatremia lost their organic osmolytes much slower, okay? They had a harder time to maintain their cell volume. And so there was a real concern about overcorrecting or rapidly correcting hypernatremia because of this concern, okay? In acute hypernatremia, though, it seemed like rapid correction was pretty well tolerated. So this was a review of case series out in Japan. They showed that one patient went from a sodium of 207 to 138 in 24 hours, actually. And patients who normalized actually had improved survival, okay? And I think the key for hypernatremia is to actually correct the hypernatremia. So this was a nice VA study. They looked at different patients with hypernatremia, and they showed that if you corrected slowly, your mortality rate was higher. It was from 46% compared to correcting normally. Quickly, and quickly was around 12 milliequivalents per liter. And then, but of the ones who corrected slowly, actually only 27%, so less than a third of them were actually normal natremic at 72 hours. So they were persistently hypernatremic, the ones who corrected slowly, okay? So I think the key is we want to correct the hypernatremia, okay? Instead of leaving them hypernatremic. And there's a couple of retrospective studies that show that maybe fast correction rates really have no influence on neurologic outcomes. So the study on your left is a study that was done out of Mount Sinai. It looked at different all ICU hospitalizations, and they looked at rapid correction rate of more than 12 versus a slow correction rate of less than 12. And the 30-day mortality was the same between the two, and there were actually no cases of cerebral edema that were noted. The study on your right is a study that was done in the pediatric cohort, because a lot of this data comes from the pediatric cohort. And again, rapid correction had in 200 children, there was no associated change in mortality or neurologic outcome. So I think despite this, it still would be reasonable to do a slower correction rate in someone who already has cerebral edema or you're concerned about developing cerebral edema. Maybe they have a large MCA stroke or something like that, right? But by and large, in most patients, I wouldn't worry too much about it, okay? So a couple key points for sodium disorders. use the sodium to guide you to the right diagnosis. I think if that's the most important thing, because your therapies are going to be impacted by that. Okay. And it's okay to recheck the urine. If someone is not responding the way that you think that they should, then just recheck the sodium. Like I always say, the kidneys are not going to lie to you. They're going to tell you what they're sensing. Okay. And then I would say determine your correction rate of hyponatremia based on osmotic risk. A lot of it's underlying based off the underlying cell physiology. And then don't worry so much about overcorrection hypernatremia in most cases. So thank you for your time. I'm sorry that was a little bit of a whirlwind, but I really wanted to go through hypernatremia. This is the podcast. This is all of us on the podcast. So, and a couple of our illustrators, Edgar, he does a lot of the social media stuff. We're on Spotify and Apple iTunes and things like that. So anyway, I appreciate your time and attention. Happy to take any questions. So. I know, I'm sorry.
Easy question, but back in the really old days, we actually used to give alcohol because it was able to inhibit ADH.
Oh.
But now when you look at reports like beer potomania, the alcohol seems to be it's not helping the people who are volume overloaded. Maybe it's just being overwhelmed by the amount of volume. And I noticed that you had alcohol up there as a risk factor for everything. So, should we be warning people that your sodium can go up, your sodium can go down, and just stay away from it?
Yeah, I mean, I think a lot of the issue with alcohol is probably not so much the alcohol, but the low solute intake that you get in the setting of chronic alcoholism. I mean, how many patients are just, I don't know, but drinking and not also taking in calories associated with it. And we definitely know that low solute can increase your risk of overcorrection because you have that impaired free water intake. Alcohol is essentially, there's no solutes in alcohol really. So.
Well, thank you. Oh.
Yeah. Hi.
So in the dialysis world, large fluctuations in volume are associated with negative CNS long-term outcomes.
Right.
So I'm wondering, for example, in an endurance athlete that might have some fluctuations in sodium over hours.
Mm-hmm.
Do we have any data on long-term CNS outcomes or long-term cardiac outcomes if there are small but frequent fluctuations in sodium?
Yeah, not that I'm aware of. So that's a really good question. Not that just like we think that small and frequent AKIs can give you long-term CAD, it would make sense that long and frequent, osmotic stresses on the brain cells would also give you long-term, but I don't think there's any studies that look at that specifically. Yeah, it's a good question, a good thought. Yeah. Yeah.